I'm Dr. Vicky Enne. I'm a Senior Research Fellow. I was based at University College London while this work was conducted. I'm currently based at King's College London and Guy's and St Thomas's Hospital. The Inhale study is a research programme funded by the UK Institute of National Health. It was a 7-year research programme designed to investigate the utility of molecular diagnostics for hospital-acquired pneumonia and ventilator-associated pneumonia in critical care. We started by doing a diagnostic evaluation, comparing a few different available technologies and also doing an observational study looking at the patient population. Based on that diagnostic evaluation, which compared different technologies, we chose the BioFire Filmary pneumonia panel as the best performing and most suitable for our clinical trial, and that was based on it had the best sensitivity and specificity for pathogen detection. It was also faster and smaller and easier to use. We conducted interviews with users and they preferred the test to the other available options we were comparing. Inhale was a randomized clinical trial. We chose that methodology because randomized trials are our current best practice for evaluating new interventions in healthcare. So in this case, a diagnostic intervention. It gives you the best independent result. It was a multi-center study, again, for the same reason that we wanted to assess its performance in different settings. We had 2 outcomes, and we essentially looked at antibiotic stewardship and clinical cure of pneumonia. And we chose those because we thought it may have an impact on the way people prescribe antibiotics. And we looked at clinical cure because we wanted to see how it impacted patient outcomes. The randomized control study was recently published in intensive care medicine. We had 2 primary outcomes. One was antibiotic stewardship, which was measured as active and proportionate antibiotics at 24 hours. So people were having antibiotics that covered their pathogen and were not too broad. So we wouldn't want, for example, meropenem for a Haemophilus influenza or anything like that. For there, we really had a strong result. So in absolute terms, 21% more people who had the BioFire pneumonia panel had active and proportionate treatment compared to this control group, which was basically standard care, so culture-based diagnosis. For our second co-primary outcome, clinical cure of pneumonia at 14 days, the non-inferiority margin was not met, so clinical cure could not be said to be non-inferior in the intervention compared to the control, but there was also no statistical difference between the 2 groups, but the non-inferiority margin wasn't met. We had a number of other secondary outcomes. The intervention arm did better than the control arm in all of the antibiotic-related secondary outcomes. In terms of other main clinical outcomes like mortality, length of stay, ventilator-free days, and SOFA score, the 2 arms were equivalent. We had a health economic analysis looking at the cost of the intervention, and we found that the intervention arm was just under £10,000 cheaper per patient than the control arm. And that probably relates to, while the differences in length of stay were not significant, there was probably enough of a difference to make an impact on the overall cost of the hospital stay. Obviously, if the cost savings are replicated in other settings, that could have a great positive impact on intensive care budgets. This being a research program, so as I said, we looked at the clinical trial, we looked at the health economics, we've also looked at the clinician behaviour. So we had a team of psychologists looking at clinician behaviour and why they prescribed certain antibiotics guided by the BioFire FilmArray panel. Essentially, the clinicians could be divided into two camps: those that used the test to narrow their antibiotics where appropriate, and those that did not. In those that did not, essentially their prescribing behaviour was driven by concern for the individual patient they were treating. So they were most concerned that the individual patient that they were treating would get the best possible antibiotics, and less concerned about antimicrobial use and perhaps the societal impact of antimicrobial resistance. So they were more worried about negative impact on the patient or negative impact for themselves, or perhaps pressure from colleagues. So those concerns for that patient drive prescribing, as opposed to worries about antimicrobial resistance. So we think what we've shown is that this test can be implemented at the point of care or even in the laboratory, and it's going to deliver results to guide patient treatment much faster than standard care. We found that results in the intervention arm could be delivered to the clinician's hand in under 2 hours when we use the test at point of care, compared to 3 days for the standard of care microbiology. So it can absolutely be used to guide antimicrobial treatment, but because of our clinical cure outcome, which is not yet fully understood, it may be something, may have just been pure chance, or it may have been something to do with slightly narrower antibiotics in the intervention arm. So we would urge some caution in using this test to narrow antibiotics too much. Any narrowing of antibiotics should be done with the supervision of an experienced microbiologist in an MDT setting. Another point about the findings was that our study did run during the COVID pandemic, and in particular some of the patients that did worse in the intervention arm were people with COVID. So we think that perhaps the results would be less pronounced in a population without COVID. So I think the future impact for the study is more people are potentially going to have results-directed therapy faster. I think it can bring real benefits in improving antimicrobial use and hopefully reducing antimicrobial resistance in the future, while making sure that people are being treated in the most appropriate way as quickly as possible.